Good evening to all. Thanks for opportunity. There is a variety of presentation of stiff hand, which needs individual evaluation and treatment. Hand has a tendency to stiff, and if it is not attended, it will stiff into a position of non-function. Like this, in this example, wrist is stiffened into the flexion. So this is most of the time this stiffness can be reduced. Like this patient was fixed with K wires, and basic principle of fixation was not followed, and principles of immobilization was not followed, and leads to stiff hand into extension at the MP joint, and it is very disastrous condition to deal. So just to summarize this case, this Ganna machine injury, he landed at 10th day and initially debrided. And now we are predicting a lot of stiffness in this condition. So after debridement, we try to heal the wounds with the hand frame, which keeps wrist into dorsiflexion and MP joint at flexion and IP joint at extended. And after 10th day, started mobilizing the MP joints and IP joints with the rubber traction off. So you can see a reasonable uh, range of movement at the of the hand, and he is able to perform all the function. Only the principle of keeping the immobilization were kept in mind. And but in the lateral view you can see there is a lot of movement at the MP joint only, and IP joints are stiff. So we are able to achieve good results. So evolution of stiffness is most important while treating these type of hands. The stiffness in the hand can be direct or indirect. Like in this example, patient had difficulty in moving the PIP joint, and on X-ray he is having PIP joint fracture dislocation. So this is a direct cause of stiffness in the hand. This lady had this malunited lower end radius. So inside the injury is at the lower end radius, but patient presented with the stiff fingers. So this is the indirect cause of stiffness. So what is the pathophysiology behind the stiffness is the edema. As told by our teacher that edema acts as a tissue glue. Once the edema occurs in the hand, it uh, floods all around the normal and abnormal structures, and especially in the MP joint. MP joint have a lot of space while extension. So MP joint becomes extended and the flexor tone increases and PIP joints get into flexion. So when these conditions are left untreated or adequate measurements were not taken, it leads to fixed stiff joint contracture. So we have to do measurement to prevent the edema. So etiology for the flexion restriction and extensile restriction can vary from skin to bone block, and I will not going to enumerate the exact cause. So we have to think of these causes to get the exact etiology. For the clinical examination part, first of all, we have to assess the range of movement at the joint. So there may be three type of conditions. Once the passive range movement is more than active range movement, and passive range is equal to range of active range movement, and there is no range of movement. So whenever first condition is there where the passive range is more than active range movement, our suspicion is the musculotendinous structure is the cause, and it may be adhere or it may be incompetent. So and associated contracture may be present. In the second condition where the passive range and active range are equal, we are suspecting any bony block or capsular injury. So first we will go for the X-ray, and you can see any articular incongruency or heterotopic calcification around the capsule or collateral ligaments. If X-ray is normal, then we will go for the 3 Tesla MRI, and we can find any problem in cartilage or ligament. And this third condition, when there is no range of movement, the evaluation for the cause is very difficult. So in this type of situation, we will try to get some range of movement. So we'll understand with this example. This is a patient having multiple metacarpal fracture, and patient was told by the surgeon that he had some vascular problem, and he fixed with the straight K wires, and he presented with this condition with all fingers straight. We started some movements and able to get some range of movement at the IP and some range at the MP joint. Now we are trying to assess what is the level of affection. It may be adherent extensor tendon or other the flexor tendons. Then second thing, we have to assess the relative joint movement. This Bernal test, we all know when MP joint is extended, there is less PIP joint movement, and when MP joint is flexed, patient is having full PIP joint movement. This is known as a positive Bernal test, and it shows the intrinsic muscle tightness. Intrinsics may be introsei or lumbricals. So lumbricals, as we all know, they inserts from the radial side of the joint. So we test the Bernal test in both radial and ulnar deviation. If the Bernal test is more tight on the ulnar deviation, then it is the lumbrical tightness. And when it is a symmetrical tightness, the introsei is the cause. So then we will assess the extrinsic tightness. Extrinsic tightness, for this example, this baby, she is flexing the wrist to get finger extended. So flexors are tight. When wrist is dorsiflex, she is not able to extend the fingers. Extrinsic tightness may be due to extensor. This man, he presented with decreased range of movement at the MP joints. You can see the decreased MP joint movement at the index and middle, and slightly at the ring, and little finger is okay. And there is suture reaction at the dorsum of the hand. When we explored, so this is example of the extensor tendon tightness. We explored the extensor tendon were found adherent. So after evolution, we have assessed the cause. Then we have to go for the treatment part. And most of the time, this treatment is non-operative first. We will understand the principle with this example. This 25-year-old male operated elsewhere, some vascular repair of radial and ulnar artery, and tendon was also repaired. And patient was referred to me for the nerve repair. And on the examination, he had stiff hand, no finger movement, and he was a lot of agony. With this condition, no movement at all at 1 month duration. So first we applied this static splint, anti-edema measures were taken care, and then we used when some movements occurred, then started some ADL, some range of movement activity, and low load stretch were applied. And patients, most important, patient was reassured because he was in too much agony about the future of his hand. Then we started getting some range of movement. And this is example of serial splitting. Although this is not the same patient was having flexion deformity, and gradually it is straightened. And ultimately, this is from about 90-degree flexion to straight PIP joint were achieved. So serial static splint gets tissue at its maximum excursion, and next stage we get more excursion. So now the same patient presented with this stage, and now he is having some range of movement. Now we can plan for his nerve surgery. So sometimes we have to use dynamic splints. Dynamic splints may assist the flexor, so known as flexor assist, or may assist the extensor, so it may be extensor assist. We understand with this example, this patient humerus was fixed and he had radial nerve palsy. So this, as in the previous talk by Dr. Praveen, he told that the dynamic splints, they are important cause for MP joint extension because they keep MP joint in extension. So patient presented with loss of movement at the MP joint. So patient was having some responding to manual stretching, and then we started using this flexor assist. So there is continuous traction at the MP joint, and then we we were able to achieve the flexion movement. Same principle can be applied when you need extensor assist. Serial casting is necessary when there is severe contracture. We will understand with this example. This patient had forearm fracture, then tight bandage were applied, and he presented with this grotesque deformity. Initially, we fixed with the straighten the forearm. Now there is tight contracture around the wrist. So this was the condition. So now it is very difficult to manage with the splint. So serial casting can be used. So gradually we corrected the wrist. Once wrist in, we are able to achieve wrist neutral, then MP joint is blocked, and started working on the fingers with the cotton. Soft padding is required because these patients have sensory problems also in the VIC. And once it is if fully corrected, then we can start using wrist splints. And then finally this condition is so this condition can be achieved with the serial casting. So surgical release if is required when there is normal or relatively normal articular surface of the joint is there, joint motors are intact, and all non-operative modality has been correctly applied and adjusted. And finally, the diligent, educated, and compliant patient is the most important thing, because if it is post-operative therapy program is not followed, the recurrence of contracture is a certainty. So I will give some example. This 48-year female presented after 1 year. She had some minor injury around the PIP joint, but she is not able to extend PIP joint. She presented with about 90 degree of flexion deformity at PIP joint. We initially tried with serial casting and then sprinting, but it was it was so rigid, not able to achieve any movement, and patient was so keen to get corrected. So when we opened, there was a thick fibrosis around the flexor pulley system. We able to when these are released, we are able to achieve some extension, but ultimately volar plate is released, and you can see we are able to achieve this full extension. But gradually mobilization was started, but within 1.5 months, 20-degree flexion contracture was achieved. But we have to satisfy at this point, because this C has achieved from non-functional range to functional range. So I will conclude my talk that evaluation of cause of stiffness is utmost necessary. Conservative treatment is the main modality and successful in most of the situation. Surgery should be opted when non-operative treatment is exhausted. Diligent, educated, and compliant patient is the prerequisite for any surgery. Surgeons should be well aware of rehabilitation with good coordination with competent physiotherapist is requirement. I should be thankful to organizer for the opportunity.